just get to make decisions now, not having to do prior auth, not having to call an insurance company. So the
Insurance, yeah.
insurance plan may not like it because now they don't have control of that dollar.
And when I looked at your model, it attacks the right areas, right? You don't want to be doing primary care, makes sense. ER,
Yeah.
that's where insurance is for. You mark down the surgical points of the most friction oriented or friction prone areas of a healthcare journey, right? The simulated journey of a knee patient. Now, I want to switch now to a buyer perspective, right? So traditional insurance leans on pre-approvals or prior authorizations, right? So, and you have zero prior authorizations. The system is fixed fee. So how do you stop overutilization without, the usual guardrails as we talked about, where prior authorization was considered as a gate? So
Right.
how does that overutilization is taken care of in your model?
So I'll go back to like, I think the 80s. I wasn't in practice then, like, even into the 90s, early 2000s. You had, the HMO model was pretty
Hmm.
prevalent at numerous points way back then. And the HMO created a gatekeeper model, right? So primary care had to be the gatekeeper. And there was
Hmm.
kind of a per member per month thing attached to it, but it didn't work for a lot of reasons. One, there was way too many levels of administrative bloatedness to make a model like that work. And the dollars weren't flowing to the providers. It was really just being kept at the insurance level and trickling down to the providers to try and make this gatekeeper model work, which just was incredibly ineffective. And so it flipped back over to people got tired of that. This isn't working. And
Hmm.
so fee for service really started to gain some steam. You started getting these massive PPO networks and insurance companies. We're kind of like, listen, we try to do it this way. We'll just make it PPO so patients can go where they want to go as long as they're in your network. Your your primary care provider can refer you anywhere you want to go. Well,
Hmm.
big PPO networks are really expensive. And as much as they've been trying to make some differences in value-based care,
Hmm.
there's still big gaps in value-based care, high quality care when you just look at a PPO network that's really, really broad. How do you manage that? And most of them aren't managed very well. How
Hmm.
how we work is more back to the gatekeeper model, right? So people are going to say, well, you're disincentivizing that surgeon from doing surgery because they're being paid a PMPM.
Hmm.
And so now the surgeon's going to say, well, if I do the surgery, it's going to knock down my PMPM. Well, we contractually address that. And also, if we have any providers in our network that are operating as such, that is certainly against contractually what we have agreed upon, and also will not be a fit for our network. Our providers
Understood.
are very happy with how we have this set up at this point in time. I've had very few no's, and the no's really aren't based upon they don't believe in the model.